Tell me a little bit about how you got into gynecologic surgery.
I was originally going to be an orthopedic surgeon, and had told actually friends that there were two specialties knew I wasn't going into, and OBGYN was one and psychiatry was another, and was found that the obstetrics and gynecology just had a nice balance of medicine, surgery, and continuity of care for patients, and became very much more something I really enjoyed doing and helping patients. So.
That resonates with me. I was going to be a plastic surgeon until the last minute, so so I get it. What to you makes a good gynecologic surgeon?
I think that especially in urogynecology, starting out with being a really good listener is crucial. There are so many different, not particularly yet data-driven options that we provide our patients that can affect many different parts of their quality of life. And without being a good listener, you might just jump to interventions that are inappropriate. And so I think it's really crucial to start with being a good listener.
As you were on your own path and journey to becoming, a good gynecologic surgeon, somebody's contributed to our surgical specialty. Who were some of your mentors or sponsors?
So I would say that starting out in my medical school training, Dan Riddick was the chair of OBGYN at UVM Medical Center, and he took me under his wing. When I said I was interested, he said, I want to meet with you every week until you match in OBGYN. And then in residency, I have to really mention two members of SGS, and they are Nicolette Horbach and Abner Korn, who both brought urogynecology to me as far as a field I wasn't considering. I was actually considering going into GYN oncology, and found that it was a really innovative and new place to start a career, and a lot of openings for research. So, and then having matched with John Delancey for a fellowship as his first fellow at Michigan, certainly was the big foundation for me, and working with Mike Aronson at Tufts. So those are really the people that stand out.
And yes, everything's edited and clipped. You're going to look amazing. The theme of this upcoming meeting in the spring is surgeons as change agents. What does that mean to you, and what changes have you seen in your sort of practice and in the field as you've been, in your sort of contemporary practice, and what changes do you think might be coming?
So I've thought a lot about this question because my career, I started out doing a lot of procedures that I don't do as frequently anymore. I did a lot of sacrospinous ligament suspensions using the Michigan four-wall suspension with innovation from George Morley and John Delancey at Michigan. I do them on an intermittent basis, but I came out of training realizing that I needed to offer some other options, and give credit to Peter Rosenblatt for being willing to have me come and scrub with him to learn some laparoscopic skills that I didn't feel I was up to par for. I actually had moved to Dartmouth at the time, and Peter was still in Massachusetts, but I still had my Massachusetts license. So I was able to refer some patients to him and come down and scrub with him. And so change, I think during our careers, we learn every day. And I think being open-minded about what you are offering your patients, making sure that you're up to date on research is, and the current outcomes is really important. And so I would say that that's where I would say it's important to keep up with. I do have some concerns about our training currently, and that we don't seem to be focusing as much on vaginal surgery for our fellows. And there's it seems to me some programs that are offering just one tool to be able to care for our patients.
It's funny. I hear you. When I was interviewing for the position in San Diego, the discussion, they were very focused because in San Diego, the fellows spend half the time at Kaiser and half the time at the UC in the UC system. And at Kaiser, they do almost all minimally invasive sacrocolpopexy. It's like 80% of patients, that's their surgery. And so there was when I was a fellow, when I was applying for fellowship, there was a concern about whether you were going to get enough MIS surgery, right? And am I going to get enough laparoscopy and or robotics? And most of the programs, a lot of them were doing predominantly vaginal surgery, 13, 15 years ago. And so now it's like the pendulum has switched. They wanted to make sure I was going to do vaginal surgery if I was going to join their group, that I wasn't too heavy in minimally invasive surgery. So that was an interesting sort of discussion, and I think that's what's, it's going to keep doing this.
Well, and I think for SGS, this is something that certainly we need to focus on. We have embraced minimally invasive gynecologic surgeons, and I think it's a great and forward for our membership to be a smattering of all benign gynecologic surgeons. But I think we're going to need to sort through how we are offering our training and to be able to keep that balance and not lose the skills from vaginal surgery.
Speaking of SGS, so I'm going to shift gears a little. What has SGS meant to you and for your career?
So SGS is a place that I feel like you can look at the mission statement, and it's providing education and research for the care of gynecologic surgeons, and I'm not going to do it justice in my trying to summarize it, but I really feel like it's a place that we learn gynecologic surgery from others. We have a very collaborative style for our annual meeting with I think the discussant and being all in one room is really crucial. And we've talked on the board about are we getting big enough that we start doing breakout sessions? And unanimously, I think everybody said, no, we need to keep the same, what Vivian Sung called the special sauce of SGS, and to be able to keep that dialogue going. And that also, I think it's important to figure out what the right size meeting is for that. And if we get too big, it becomes harder to do that. Mike Aronson is the first one who suggested I go to an SGS meeting, and that was when they always were held in New Orleans, and they were first all combined with the ACGME or APCO-CREOG meetings, but they were always in New Orleans. So my first meeting was in New Orleans, and soon after that, the board realized that it needed to move around, and I think it's been a great journey.
Other than that, any specific memories that sort of make you smile, or something that sort of is near and dear to your heart with regard to SGS, or sort of some people have talked about these like moments on the podium that were challenging, but any memories that you can think of?
I think that there are some of the kind of giants in our field, to be able to watch them get up and ask a question, usually in a very diplomatic way and not put somebody too much on the spot. But I think, being able to then sit down and talk with somebody that you was kind of held on a very high podium and would never have had that opportunity at some of the bigger meetings that we have.
Yeah, somebody else said that is that so many people that you admire or have, either read their work or, we're such a small field, but that everyone's at arm's length at SGS. and everyone's really willing. If you just tap them on the shoulder and ask them to sit down for a minute, everyone says yes. And whereas at our meetings like OGS and AGL, it feels so congested and so overwhelming, but SGS, everybody sort of is accessible and willing, which is what others have also been saying. So I'm already picturing the montage of these sound bites. Okay, so our sort of fun question, which will be a fun montage too. Favorite surgical instrument and why?
You stumped me for a sec. I'm going to have to think about this one.
It's hard to pick one. That's why. I mean, we all have our favorite things on our trays, but one, and it's not the only one you would ever need, but one that sort of you feel like, and I've had some really simple answers and some really intricate, complicated answers.
Yeah. I mean, I think, I guess having most of my career has been with vaginal surgery, that probably the most crucial instrument. I feel like if I don't have one available, I would be in big trouble as a Breisky retractor.
Yeah, you're in good company. That one came up at first also. A lot of people have said the Breisky. Both Deb Myers and Dee Fenner's most important instrument is the suction. It's the sucker.
Yeah, well, I actually had an attending when I was a resident who could essentially do a C-section with a sucker.
Yeah, that's what I forget which one of them said that, but said I can basically do an entire procedure using it. But I thought, and then my follow-up questions then was, do you let anybody else hold it, or are you the only one who holds it if you're assisting? But
I actually have one of my fellows and I did a video on assisting for vaginal surgery. And I actually think that teaching assistance is probably as important with vaginal surgery as the person sitting down doing the surgery. And so we actually alternate. So the person looking across field holds the sucker and helps with assisting. And so I will engage the med student if they're the other assistant to do clamp releases and hold the suction if they're on that side. So opposite side holds the sucker.
That's a good idea, actually. That's a really good idea.